Yes, thank you so much, Dr. Mayuriben, for including me in this amongst these learned speakers in glaucoma. So my previous speakers have made my job very easy. They have narrated all the imaging techniques in glaucoma so far. So I will directly move on to my topic of the day, that is UBM in pseudophakic glaucoma. Here is the normal UBM picture of a phakic eye, and this is UBM in a pseudophakic eye, where rest of the anatomical configuration is normal, and most importantly, IOL is not in touch with uveal tissue anywhere, which is the culprit to make the problem. So I always salute these people who have invented this interesting and amazing technology to view the anterior segment so nicely, but I don't have any financial interest to share. In the latest publication on UBM in pseudophakic glaucoma, it has been stated that almost all the causes can be detected by UBM except a very few. So, in very small number, like corticosteroid-induced glaucoma, we cannot make out the real etiology on UBM, but rest of all can be very well delineated on UBM. So, role of UBM in pseudophakic glaucoma is mainly to access the causative mechanism, and thereby we can plan for the management. Here we can see posterior synechia doing optic capture, and in turn peripheral anterior synechia. These causes can be divided for this ease amongst IOL related causes, surgical procedure related causes, intraocular inflammation following surgery, and some pre existing causes at times, but they are very greatly interrelated. We cannot 100% depart one from the other, and thereby, mechanism of raised intraocular pressure we can make out in pseudophakic eye. Main culprit is IOL malposition or tilted IOL. Usually in these cases, there is corneal edema. And so slit lamp examination, gonioscopy will have some limitation. Practically, on UBM, we can see IOL anywhere inside, maybe floating in aqueous, maybe tilted in its place, but elevating the iris by its haptic, or optic itself may be in contact with endothelium. It's not surprising to see more than one intraocular lenses inside when you use UBM for diagnosis, one floating, the other scleral fixating, entangling the uveal tissue and irritating. Here, slit lamp doesn't show any presence of intraocular lens, but it is tilted and hidden by the iris in the vitreous. Some people are very enthusiastic and put PCIOL in AC, and we can know that it is irritating the angle all the time. Or there may be all round optic capture, and IOL is swinging inside, and haptics are lifting the iris to be pushed in the angle. Malignant glaucoma, as described by my previous speaker very nicely, there is no posterior chamber, which is the most important diagnostic feature. During surgery, if there is posterior capsule rupture or zonular descents, then vitreous will prolapse in the AC. If it is fully covering the pupil, there is pupillary block, or it might be touching the endothelium and the lens is floating in the vitreous, then we can know the cause. In some cases, there is excessive lens matter, which results into Somering's rings, and that also at times blocks the pupil, causes secondary rise of pressure. At times, we can get the total anterior synechia, iris totally adherent to the corneal endothelium. Scleral fixation IOL, haptics are irritating the ciliary body all the time. There is, or at times, the IOL is halfway in anterior chamber, half in posterior chamber, one haptic in angle, the other one on the ciliary body. Or there may be gross damage during surgery, resulting into Descemet stare, optic capture, and posterior synechia, and thereby finally peripheral anterior synechia. Or there may be iridodialysis, lens tilted so much that the haptic is pushing the iris in the right in the center, causing peripheral anterior synechia. At times, we come across certain pre-existing causes like plateau iris and pigmentary glaucoma, that is posterior bowing of the mid-peripheral iris. Intraocular inflammation is evident by presence of the exudation, maybe so much of exudate with iris inflammation or pupillary membrane, excessive exudation directly clogging the angle and trabecular meshwork or trabeculitis causing glaucoma, and in a long run there is extensive fibrosis. This is the most common picture seen in cases of pseudophakic glaucoma, that is chronic postoperative uveitis will cause posterior synechia, may be causing optic capture at the edge or in the center of the lens and thereby pupillary block. So there is iris bombi and after few days or hours, it will be resulting into peripheral entry synechia and a damage in form of glaucoma. Or as I told you, optic or haptic may be causing uveitis by touch to the ciliary body or iris. This is not unusual to see, that is iris cyst formation due to inflammation, and glaucoma is bound to occur. Following triple surgery, we can see synechia either at the edge of the host graft junction and secondary glaucoma, or it may be because of the optic capture. Excessive lens matter following surgery may be in the angle, maybe in the angle or in antechamber, and in some cases it is so much that it is pushing the IOL forward and thereby pushing the iris and causing peripheral entry synechia. Presence of silicone oil and zipping of the angle by neovascular glaucoma all are evident. In this patient, in certain quadrants, the angle was narrow and UBM showed that it is being pushed, iris is being pushed by the haptic of the lens on one side. This young myopic had both eye phakic IOL. One eye he was very happy, the fellow eye, intermittent redness and diminution of vision, and all the examinations, slit lamp, gonioscopy, ASOCT didn't show anything. And then UBM showed that the phakic IOL was inserted upside down. It was removed and reinserted. Patient was very happy thereafter. In the same way, if there is intense ciliary body edema, it will push the IOL to one side and cause chronic irritation in the eye, secondary glaucoma. After a month, it diagnosed by UBM, which is not possible by other techniques. And after a month of treatment, patient was very well. In pediatric pseudophakic glaucoma, also excessive lens matter or excessive fibrosis, as we suspect, will cause secondary glaucoma. This is just to compare. It's a beautiful delineation, but the cause will be evident on UBM only. So, to conclude, ultrasound biomicroscopy has a unique role in evaluating the etiological factors responsible for pseudophakic glaucoma, and thereby we decide our plan of management, and patient is very happy finally. Thank you. Thank you so much for including me in your team. Thank you, Mayur.